Hi, everyone. This is Module 1, Unit 4, and in this module, we're taking some time to situate why qualitative research is relevant to a health equity research agenda, or I should say a health equity agenda with respect to research or practice. This module is a little longer than the rest again, to kind of orient ourselves in these issues of health equity. So at the end of this maybe 20-minute module, we hope to be able to help you explain how health is produced. So thinking about health as part of a social production, and if health is part of a social production, how health disparities can actually be man-made, and health equity is something that we have to create systems to produce. We hope will help you distinguish between the structural drivers of health inequities and the social determinants of health. We talk more about the social determinants of health in which we are born, live, work, play, pray, rather than those drivers within our structures and systems that produce the inequities that we live with. And then importantly, try to describe why then are qualitative methods relevant to what we call the critical health equity agenda. And what we mean by that, and it was referenced in a few modules earlier, is really critically thinking about ways in which health inequities are produced and ways in which we would have to produce health equity then. So I just want to start with talking about some trends that we see in qualitative research. Let's see if I can get rid of, there we go. Some trends that we see in qualitative research and therefore the role for qualitative. So we see an increasing interest in and trustworthiness, I should say, of social, behavioral, and cultural perspectives. So an increased emphasis in public health in particular, of course, but other disciplines, on the impact of ecology, of context, of lived experience. And this appreciation of contextual effects puts us in a position to introduce qualitative, because the complexity of the ecologies we live in and the context that determines our health, or the context that influence our health, is actually well suited to qualitative methods. Qualitative methods are really good for helping us to unpack, explore, understand, rather than, of course, as we said earlier, to think about causation. So qualitative research can be really good for processes rather than outcomes. In public health research and practice, we've done a lot of work at discerning the differences in health outcomes by groups identified by social identities, rather than these processes through which health is produced, or health inequities are produced. So moving away from an interest then in disease outcomes, we're thinking about social factors that determine our health, or social determinants of health. So these community, these cultural, these contextual, these ecological influences are what qualitative methods are really good at. Pure qualitative methods might be being accepted slower than we'd like to see in public health research, but it's at an increasing pace. But there is definitely a call for mixed methods, so mixing a quantitative and a qualitative approach, both to get the hypothesis testing, descriptive kinds of insight, and the qualitative kind of deeper exploration. So why should we consider qualitative approach in public health? First is because if we believe in this idea of health equity, that everyone deserves the opportunity for health, then we have to think about how do systems and structures produce differential opportunities. So in order to understand those different opportunities that people have to be healthy, that we need to understand context and ecology. The second reason, as I said before, is qualitative approaches can help us really think about how structures determine our context. So if we're going to talk a little bit about kind of the stream analogy we use in public health, but we tend to be able to identify social determinants, but not identify so clearly how they emerge from structures. And talking to people through qualitative methods who have been cumulatively, historically marginalized and oppressed give us a better picture of these structural drivers of health inequities. And the other reason why qualitative approaches are important in public health really comes from the community-based participatory research as an approach to research. This is something that we invest in at UIC School of Public Health a lot, engaging in research collaboratively with people who experience the phenomena and interest, and making sure that that research is driven by communities. It is the best way to really have a strong health equity research agenda, and having qualitative research that ground our inquiry in lived experience is really kind of the gold standard of a health equity research agenda. So health equity, it's important to understand health equity. This language even is something that we've only recently been very clear about distinguishing health equity from health disparities. The United States has been slower at changing our language on this than other comparable countries that have long had a more justice-oriented approach to health production. But as we increasingly recognize the core roots, the root causes of the morbidity and mortality that we deal with in public health, we're naturally drawn to more context, place, ecology. I think the other thing that has led us to embrace more of a health equity agenda rather than a health disparities research agenda is our lack as a public health discipline of substantial systemic progress to reduce health disparities. And so we really have to engage more collaboratively in research with people and populations who have been cumulatively disadvantaged to really more qualitatively understand root causes and make change at that systems or roots level. So I want to take just a few minutes to talk about how health is socially produced, because I think this makes a really good case for why qualitative methods are important. So when we think about health in public health, we often refer to the stream analogy, which really distinguishes these upstream factors from these downstream factors. And we think about the downstream factors being people and their health conditions, morbidity, mortality, outcomes. And upstream are these more contextual systems level influences. But this kind of dichotomy of up and down doesn't really allow us to understand the mechanisms at play in producing health inequities. And so trying to move away from that stream analogy a little bit more, put together some graphics to kind of walk us through how health is socially produced. So when we think about what determines health, we think about people's behavior and their biology. So smoking behavior, wearing a condom, wearing a seatbelt, and then their genes, their DNA, their biologic predisposition to health or illness. And we understand that people's behavior and biology are influenced by psychosocial factors. So public health has made a lot of progress lately naming issues of stress and issues of embodiment. So how we experience phenomena both impact us positively or negatively, but also we can embody these experiences and they can change our biology. But when we think about our behavior and our biology and psychosocial factors that influence us and our behaviors and biology, we also want to recognize that our material circumstances, so the resources that we have where we are born, live, work, and play, are also part of the social determinants of health. So these are these social factors that impact our health. So, but what shapes our opportunities to be healthy? So what shapes where we are born, live, work, play, and pray? So the World Health Organization gives us a really nice framework to use to think about this, and they suggest that our social position, where we fall with respect to income, occupation, and education, determines those material circumstances that we live in, which influence our psychosocial factors, our behavior, and our biology. So, but who and what determines who has access to these opportunities then? So who and what determines where you fall in a particular social hierarchy or what social position you have? And the World Health Organization suggests it's really our social and our political context. So the values we have as a society, the cultural norms that we have, and the policies, both social and public policies, but also more local organizational policies that represent the values and cultural values and norms that are important to us. And our government is the way that we socially organize. So the policies typically sit within a government framework and are influenced by these values. So the social political context impacts how people are positioned with respect to a social hierarchy, and that determines one's social determinants of health, which impact their health. So the social position and the social and political context really are the structural determinants of health inequity, and it's important for us to distinguish those from what we measure more often, which are the social determinants of health. And issues of power and privilege underlie the mechanisms through which health is produced. So who is in power, making policies, making decisions that regulate our opportunities to be healthy is determined by issues of power and privilege, and whose values are reflected in our policy system are determined by who is making those decisions in a governmental context. So health inequities then aren't by chance. We're not just born healthy or unhealthy. They're actually human-made because they're based in how we organize politically and what rules and policies we put on our life. And I have one more graphic to just kind of walk us through how these things happen. So when we think about a population that might be more privileged with respect to class, to income, to race and ethnicity, to gender, versus an oppressed population, so in a population that may be left out of the decision making. We know that in a privileged population, the people who are making policy or making decisions on the policies that are going to impact where you're born, live, work, and play typically represent your interest, whereas oppressed populations are often unheard and unrepresented in this. So then we have policies that benefit just a few, those who are already in power, versus those that can be really oppressed by these policies. And this can impact the quality of education that people have, so those in decision-making roles or who's reflected by who's in power making decisions typically have access to good education, whereas oppressed populations have unsure education, poor school opportunities. And this relates to where we're born, live, work, and play, and speaks to the kinds of job opportunities that we might have. So those that might be unsafe, unpredictable versus more stable, good, healthy work situations. Our work can then impact our income, which impacts our opportunity to access health care and our opportunity to live in spaces and places that are safe. Depending on where you live, work, and play, this may determine the quality of food that you have access to and also stressors that you experience. So that oppressed populations can deal with constant life stressors, whereas more privileged populations have time for rest and relaxation. And thinking about these opportunities or barriers for health in these just two kind of polarized ways help us think about those people who then have more opportunity to participate in the political process. So this way of thinking helps us determine these structural determinants of health inequities from the social, but it also allows us to think about more these upstream issues about what determines the social political context. So again, the World Health Organization suggests that issues of power and privilege determine who's in power making decisions, which determines what the social hierarchy looks like, which then determines social determinants of health. And in our first module, we distinguished these two terms from health disparities and health inequities, but it's important to go over them again as we think about the role for qualitative here. Because if we distinguish health disparities from health inequities, as health inequities have to do with justice, fairness, things that are unavoidable, these are caused by that social, economical, and political context. They're related to issues of power, privilege, and prestige, and therefore they have these clear policy implications. And qualitative research and practice can be a way to really understand these experiences because these mechanisms that are at play are implicate kind of how people are going to experience life and therefore experience opportunities to be healthy or not. This image you saw in a previous module, but it's important to show again when we're thinking about issues of justice. When we think about issues of equality, we think about distributing resources equally. So the boxes in the image on the left are all the same size, regardless of how someone comes to the problem or the phenomena. When we think about issues of equity, we think about distributing resources depending on from where someone comes. So someone more disadvantaged will get more resources so that people can equitably participate. And we think about issues of justice, we think about both equitable distribution of resources, but also working together to dismantle systems. And so in this case, the fence is kind of representing a system, but how can we create systems that are more fair for everyone so that people can come to a phenomena more equally? So the reason why this is important to think about is that when we can name the structural drivers at the level at which structures and systems impact our health, it helps us better name the isms that we're worried about in public health. So racism, sexism, homophobia, gender discrimination, and these isms are really important because it's through the systems in which opportunities are structured. So again, if we think about social position as a structure and the structured ways in which people have opportunities to good work, good schools, good pay, good health insurance, what basically is happening is people are really assigned a value. So some people have better opportunities to be healthy than others because of the ways in which we structure opportunities in our systems. And Kamara Jones talks a lot about the two-sided nature of racism being one of our isms, that it's difficult to recognize a system of inequity that privileges you. And so one of the important reasons to walk through the social production of health is to see how the structures and the systems work together to advantage some and disadvantage others. And so going back to the previous module where we talked about research or positionality, thinking about the ways in which one is privileged or disadvantaged by the system is important to both recognize because we want to break down systems that produce that structure opportunity in that way. So just wrapping up and tying in qualitative research here, what role then do we have, and what role does kind of qualitative research and practice have when it comes to health inequities or a health equity research agenda? And I think about these in terms of opportunities to ask, opportunities to involve, and opportunities to act. So when we think about asking, when we're engaging in research, we are engaged in inquiry, so it's all about an ask. And when we think about the opportunities for qualitative research deliberately thinks about epistemology. It deliberately asks you to be transparent about your worldview and how you're coming to know a particular phenomena. This allows us to think about what is the history of this issue, what will we be measuring, does this make sense from a health equity perspective, whose data are these, what kind of evidence does this produce. Qualitative research also helps us think about the degrees of inequity, so who benefits and who is harmed by this particular phenomena, and how does our research seek to advance health equity. When we think about involving, this can be both in our research or our practice, but as we said before, qualitative research is focused on inclusion. So thinking about involving people who are typically left out, that means having diverse stakeholders, but also having inclusive structures that address power imbalances, and thinking about why marginalized or oppressed communities have not been represented and why they might be reluctant to engage. Linda Sarsour helps us think about this idea of engaging communities and finding a seat. So when we think about making sure that people are included, we think about kinds of inclusion, so diversity, equity, inclusion, and justice. And diversity kind of asks, so who's in the room? Do we have a diverse enough representation? But equity asks, so who's trying to get in the room but can't? and who's present in the room is constantly under threat. So who's in the room but not heard. Inclusion is really, has everyone's ideas been heard? And justice is whose ideas won't be taken seriously because they're not in the majority. So making space, making structures for inclusion, whether in our research design or in our practice, is really important. And thinking about when there isn't a seat that some people might sit on the table, and that is to claim space. And qualitative research and inquiry should be committed to making sure there is space for people. Community engagement is very closely linked to qualitative research, and so just a couple slides on community engagement. It is actually critical to a health equity agenda, as is qualitative research, because of the power of united action. And the World Health Organization framework has helped us think about how government, so the state, has a responsibility to make systems that encourage interaction. So policies that discourage interaction are problematic. And engaging people in the process, again, whether it's research or practice, making sure people's voices are heard, either qualitatively, has a very transformative potential, both for marginalized, historically marginalized, oppressed populations and our discipline of public health. So the last point is really our opportunity to act. Qualitative research really gives us an opportunity to provide new insight on phenomena that haven't been understood through traditional methods. It allows us then to build power through knowledge. Angela Glover-Blackwell talks about radical imagination, really allowing for new insights that really can build our power and expand our reach and allow us to align with social movements. So that was the quick tutorial kind of on health inequities and why qualitative research is really important to a critical health equity agenda. Thank you.